Hello, my name is Rick Spade. I'm going to be talking about choriocapillaris vascular parameters in normal eyes and those with pachychoroid with and without disease. These are my disclosures. Pachychoroid is really an incomplete and poorly defined entity. A recent literature review that's going to appear in the journal Retina looked at pachychoroid and pachychoroid spectrum diseases. Just for pachychoroid, there were 44 papers. 19 of those papers had no definition of what pachychoroid was, and the remaining 25 papers had 18 different definitions. What about other causes of thick choroid? After all, pachychoroid means thick choroid, but only includes a minority of things that actually have a thick choroid. Here's a list of many different entities that cause choroidal thickening that aren't included in the pachychoroid spectrum. Here's another big list of things that cause thickening of the choroid that aren't included in the pachychoroid spectrum. Well, to compound things, or these difficulties, pachychoroid was the definition of which was expanded. And people said, well, a choroid doesn't have to be thick to have pachychoroid, even though the word pachychoroid means thick choroid. But it did say that choroidal vascular hyperpermeability was important. Not necessarily, just important. Well, here's a number of different entities that cause choroidal vascular hyperpermeability that aren't included in the pachychoroid spectrum. Here are another series of disease entities that cause choroidal vascular hyperpermeability but aren't included in the pachychoroid spectrum. So the pachychoroid spectrum really is kind of arbitrary in what it includes and what it excludes. It doesn't have really that much clinical utility because the thickening of the choroid is really an epiphenomenon, and it's not even required in the first place to fulfill a definition of the disease. But there are people with a thick choroid, and it's kind of interesting to know what's up with those patients. Are they any different in any sort of way? So to investigate that, I did a study of patients and looked at their choriocapillaris. And I looked at normals. I looked at patients who had a thick choroid defined by population standards. So what I looked for is those people with 95th percentile thickness or greater on an age-adjusted basis. And to come up with that age-adjusted amount, I looked at older studies and picked out the upper fifth percentile in terms of choroidal thickness. And the regression equation for that was that the choroidal thickness in microns for the upper 5% was 525 minus 3.25 times the age. So there were three groups of patients examined in this study: those with normal choroids, those with the pachychoroid with no disease, that's the upper 95 percentile or more, and pachychoroid disease, still using the word pachychoroid just for historical reasons, which included patients with central serous or peripapillary pachychoroid syndrome. Those patients, by the way, also had a thick choroid. I used a technique that I devised and published in which we make a sandwich out of three different layers of the retina: the superficial vascular plexus, the choriocapillaris, and the deep vascular plexus are each put into one channel of a red-green-blue color channel picture, and that makes a composite picture. That picture may look a little strange to us, but it gives the computer something to latch onto to register and average these images. After that, you get an averaged image, and you can split them back into the component parts, and you end up with an average choriocapillaris image. Here's a choriocapillaris of a normal 27-year-old. You can see that the pattern of the choriocapillaris looks very much like histology pictures. Now we can binarize that into a white and black and white image, as I showed here. You can compare that also to a 66-year-old with central serous, and you can see not only are there areas where the blood vessels aren't, those would be flow deficits, but the capillaries themselves look different. So that we can analyze this. Once you end up with a binarized version of the choriocapillaris, we can skeletonize that, and you can overlay that on top of the skeletonized version on top of the binarized version. You can see it's quite accurate. And from that, we can either measure or calculate a number of different parameters about the vascularity in the choriocapillaris. We can count how many blood vessels there are per square millimeter, for instance, or measure the mean branch length or the standard deviation of these branches. So let's look at these three different disease groups: normal, pachychoroid without disease, and this special group, pachychoroid with disease, that is central serous and peripapillary pachychoroid syndrome. So normal and pachychoroid without disease were essentially the same for every vascular parameter. That includes mean vascular length, the branch standard deviation, number of branches per square millimeter, the diameter of the branches, and the fractal dimension. Whereas pachychoroid disease was distinctly different from both of those. In particular, the branch length was longer in pachychoroid disease, the standard deviation was greater, the number of vessels per square millimeter was less, vascular diameter was greater, and the fractal dimension was less. So, among the chorea capillaris parameters, the people who were normal controls and 95th percentile choroidal thickness with no obvious disease, same. The people, though, with disease, central serous chorea retinopathy or peripapillary pachychoroid syndrome, had a marked difference in their capillaries. This new pachychoroid study shows that increased choroidal thickness is not necessarily pathologic. And we can make an analogy to intraocular pressure over greater than 21 millimeters mercury, in which not everyone over that pressure gets glaucoma. In fact, only a minority of people do. By definition, 5% of the population will have a pachychoroid by this definition, but it illustrates that they don't necessarily have any disease or any problem. It's the first study to measure chorea capillaris parameters in health or disease, defined pachychoroid according to an age-adjusted thickness as opposed to some arbitrary definition, and by doing so allows greater precision and disease definition and understanding. Thank you for your attention.
I would like to thank the committee for the very kind invitation. And the topic is about hydroxychloroquine and hydroxychloroquine retinopathy and its multimodal imaging. And hydroxychloroquine is a drug that has been recently placed at the forefront as treatment during the COVID pandemic. But its use has been increasing in rheumatic and dermatologic conditions. Hydroxychloroquine retinopathy is a sight-threatening condition with a prevalence estimated at 7.5% and a risk is up to 50% in patients taking this medication for a period longer than 20 years. Risk factors include the dosage, apart from duration, renal disease, tamoxifen use, whereas the presence of macular disease could be a confounding factor in the assessment of its macular effect. The Royal College of Ophthalmologists has established guidelines for the screening of hydroxychloroquine retinopathy, and it includes standard imaging modalities as color photography or cross-sectional spectral domain OCT, both at 6 to 12 months from starting treatment to after 5 years of use, alongside a 10-2 visual field, wide field autofluorescence encompassing macular and extramacular areas, and also 30-2 visual field if the 10-2 visual field is abnormal, and multifocal electroretinogram. The standard imaging findings include a visual field defect located centrally or paracentrally, along with flattening of the multifocal ERG waveforms in the central area or in the extramacular area. The spectral domain OCT does present with loss of the ellipsoid zone located in similar locations. But it is important, but the importance of early recognition cannot be emphasized enough, despite the presence of a rule of thumb, which is when retinopathy is recognized early, there's mild or limited progression and fovea is not threatened, there is progression. And this progression has been indicated, especially in this recent paper by Emily Chu's group in Retina 2019, in which even in the subtlest form of hydroxychloroquine maculopathy, there is a certain degree of progression after cessation of the medication. This progression in the form of longitudinal changes could present in 4 different stages, including further restriction of the ellipsoid zone or even collapse of the outer nuclear layer. So additional imaging modalities are important for earlier detection of this retinopathy, and I will refer to the ANFAS swept source OCT, the Hood report, and optical coherence tomography and angiography. The ANFAS swept source OCT does present evidence of loss of the RPE at the level of the outer segment and the retinal pigment epithelium layer in the form of a hyperreflective lesion and a hyperreflective area affected in the inner segment, outer segment. That would apply for more severe cases, but also in more subtle cases. And as you can see in this example of 2 cases, this correlates pretty well with the localization of corresponding visual field defects. This correlation has actually been corroborated by Ann's paper, which shows a direct significant correlation with the mean deviation, pattern standard deviation of visual field index on 30-2 visual field examinations. This modality, the unfast OCT and also the standard imaging, deals with changes located in the outer retina. However, the inner retina is also an interesting and important point and location that could present with some changes. Indeed, as far back as 2010, there was evidence of selective thinning of the macular inner retina, sometimes in the absence of clinical fundus changes. A subsequent paper indicated the presence of bilateral symmetric loss and reduction in the thickness of the ganglion cell layer and inner plexiform layer thickness. This correlation was not established in that paper with actual hydroxychloroquine use. However, some of the patients that had retinopathy or patients that did have high cumulative dose of hydroxychloroquine did demonstrate a thin GC-IPL. In our group, we have been using the Hood glaucoma report, and the Hood glaucoma report is a report generated from the 3D wide field OCT at the Triton swept source, and it is a report that does present concurrently any loss at the RNFL, any loss at the GCL projected over 24-2 and 10-2 visual field templates. And after examining 114 patients in our hydroxychloroquine maculopathy screening service, a symmetrical bilateral pattern was noted in 18.3% of those cases. This pattern indicated the profound effect on the thickness of the ganglion cell layer. This pattern was considered inverted in a sense in comparison to the pattern of glaucoma, in which the RNFL was minimally affected in comparison to GCL. Very interestingly, this presentation was not associated with any concurrent macular or optic nerve pathology, and there was no significant difference between cases with or without any of the known risk factors. In addition, a correlation was examined with the unfast OCT cases, and it was shown in this group, in this study, that cases with ganglion cell layer thinning did manifest these changes significantly earlier at 2.8 years, whereas the unfast defect was manifested at an average of 6 years of use. Therefore, the thinning of GCL that was encountered in an important fraction of these patients did develop early on. This year, this paper corroborated these findings, indicating that hydroxychloroquine does seem to cause progressive thinning of inner retinal layers, specifically in the GCL, without any changes observed in the outer retina. I would like to note that this population of 144 eyes did include eyes without retinal toxicity. In this particular study that did have those findings, there was no developed hydroxychloroquine maculopathy, which is indicative of an early finding. Optical coherence tomography and geography is, on the other hand, a modality that has been seminal in medical retina in elucidating many of the signs of vascular retinal pathology and has a myriad of new signs in the literature. In the case of hydroxychloroquine maculopathy, this paper by Ann demonstrated the analogous increase of signal voids in the choriocapillaris layer in conjunction with RPE loss at the different stages of hydroxychloroquine maculopathy. And other papers have also noted the choroidal thickness to be thinned, the retinal and the choroidal flow rates to be reduced in eyes that were at high risk for the development of retinopathy, whereas a very recent paper also found a reduction in vessel density, increased foveal vascular zone, and also, yet again, flow voids and reduced foveal choroidal thickness without having any other sign from the standard imaging used in the assessment of hydroxychloroquine maculopathy, indicating that these vascular changes are actually early events. Therefore, multimodal imaging of hydroxychloroquine maculopathy is of particular clinical importance in the early detection of disease and wide-range screening programs. Modalities include visual field, cross-sectional spectral domain OCT, and autofluorescence, but additional modalities might aid and should aid in the earlier detection of disease, especially due to the development of longitudinal changes. UNFAS OCT, OCT angiography, and the use of Hood report, focusing on the comparison of RNFL and GCL thickness, would be or could be valuable. I would like to acknowledge my colleagues at the Royal London Hospital Virtual Hydroxychloroquine Maculopathy Screening Service, and I would like to thank you for your attention.
Thank you for the opportunity to share our initial clinical experience of applying a Topcon-developed algorithm for automated volumetric CVI analysis. Choroidal vascularity index has been described several years ago. It is a concept that segments the structural OCT using the Brooks membrane and choroidal scleral interface as boundaries and binarizing the content of the choroid into luminal versus stromal areas as a ratio to the total choroidal area. Previously, we utilized single subfoveal OCT scans in patients with exudative AMD and described that study eyes had lower CVI compared to fellow eyes. In longitudinal follow-up studies, we also described a significant reduction in choroidal thickness subfoveally, where CVI at the subfoveal area was largely unchanged. What is new is now the ability to automatically delineate CSI as well as Brooks membrane, which saves a lot of time, and therefore we can generate a automated volumetric choroidal thickness map throughout the macular area and appreciate regional variation with much more sophisticated appreciation. We can then binarize each and every single scan and also generate a CVI map, as you can see here. In our pilot study, we specifically analyzed the central 4 squares as described here as the macular CVI. We applied this beta algorithm to a cohort of treatment-naive PCV eyes undergoing Eylea therapy over 12 months, and the scan acquisition used was the standard 6x6 macular OCT, in which we just used the structural scans, which were averaged 4 times. We correlated the baseline subfoveal choroidal thickness and macular CVI, as well as evaluated longitudinal changes in these 2 parameters. At baseline, as you can see here, the 2 values, choroidal thickness in the x-axis and CVI in the y-axis, correlated quite well with each other. However, if you look at the scale, you can appreciate that there is a much wider range in choroidal thickness compared to CVI. Here are 2 examples of an eye with thin choroid and low CVI in the left, and a thick choroid and higher CVI on the right-hand side. This range of CVI is largely in keeping with what has been described using the Zeiss swab source OCT. In this paper, they described a range of 55 to 68% in normal individuals. In terms of longitudinal changes, I have highlighted the no change line in choroidal thickness in the y-axis in red here. And you can see that over 12 months, most eyes demonstrated a reduction in choroidal thickness in the region about 20 to 30%. In contrast, for CVI, most eyes were hovering around the no change line with very little range of change, going from 96% to 102%. Here is one example showing you baseline month 3 and month 12 scans, and we can appreciate there is significant reduction in both thickness and choroidal vascularity index, and even by eyeballing we realize that at month 12 the choroid looks a lot less dark compared to baseline. There's another example again showing significant reduction in the thickness, however the CVI change was less marked in this eye. A couple of pitfalls to mention for this algorithm to be successful. A lot of blood and large PED is going to be a problem because of signal loss inside the choroid, which affects the accuracy of segmentation. And in eyes with very thick choroid, there can be suprachoroidal effusion, which can also make the delineation of CSI tricky. So in summary, we found that there is a wide range of choroidal thickness but small excursion of CVI. And with treatment, again, we found that significant thinning was demonstrated, but CVI changes were very small. This is similar to what we found previously using a single subfoveal scan. This study demonstrated the feasibility of using this automated algorithm to a standard OCTA acquisition, and the volumetric assessment allows us to appreciate regional changes much more sophisticatedly than we could previously using a single subfoveal scan. So thank you for the opportunity to share.
I'd like to talk about role of dilated choroidal vein for myopic macular neovascularization. This is my financial disclosures. Myopic macular neovascularization is the most common cause of the central vision loss in patients with pathologic myopia. It develops in around 10% of the patients with pathologic myopia and usually type 2 MNV. Interestingly, GFO reported that perforating scleral vessels were found in 71% at the site of myopic CNV. Later, Ricaud reported a case whose myopic MNV was actually supplied by an intrascleral blood vessel, as shown in the right images. So these studies suggested a possibility that myopic MNVs can originate directly from the scleral vessels. However, these are small case series and it was not clear what this scleral vessel was. We retrospectively reviewed the OCT images of our patients with myopic MNV and found that scleral perforating vessels were observed at or around the myopic CNV in 75%, as GFO reported. Scleral vessels were seen in all of the phases, active, scar, and atrophic phases. And in 10 of these 93 eyes, 11%, a direct communication between the scleral vessels and MNV was observed through Brooks membrane defects. I will show a representative case. This patient developed MNV 12 years ago, and the fundus shows MNV-related macular atrophy. The OCT angiogram of the outer retinal and choriocapital slab showed the CNV with blood flow. SWIPS also CT shows two cross sections of the blood vessels within the sclera below the CNV as shown by arrows. In an adjacent section, this vessel penetrates the outer surface of the sclera and runs toward the CNV. Finally, it becomes continuous with the CNV through a Brooks membrane defect between the yellow arrows. And today, I would like to talk about another mystery of myopic MNV. While we were conducting the previous study, we also noticed that abnormally dilated choroidal vein was often seen at or adjacent to myopic CNV. I will show some representative cases. Right fundus shows pigmented MNV. In fluorescent angiogram, it shows mild hyperfluorescence. We regularly perform ICG angiography for patients with myopic MNV. The venous phase of ICG angiogram shows a dilated and tortuous choroidal vein in the macula. Arrows indicate the MNV. This vein does not drain out of the peripheral vortex veins and seems to exit the eye upper temporal to the optic disc. So this is a macular vortex vein. In a magnified image, the nasal half of the MNV lies over this dilated macular vortex vein. In serial sections of horizontal OCT scans, dilated macular vortex vein, shown by arrows, is seen just nasal to the MNV. The choroid is generally thin besides the area of this macular vortex vein. There appears to be no choriocapillaries over this dilated vein, and this vein causes an elevation of an overlying RPE and Brooks membrane. The next patient also has pigmented MNV with hyperfluorescence in fluorescent angiogram. Venous phase of ICG angiogram shows a dilated choroidal vein in the macula. A scarred MNV with dark rim is present over this dilated choroidal vein. Ultra-wide-field ICG angiogram shows that this dilated vein does not drain to the periphery and seems to exit lower nasal to the optic disc. So this vein is considered to be a macular vortex vein. An oblique OCT scan across the fovea shows macular vortex vein indicated by blue arrows below the MNV. An adjacent OCT scan shows dilated branches of this macular vortex vein below and around the MNV. Magnified image shows that this vein directly contacts the MNV through the defect of RPE and Brooks membrane. In addition, some patients have the connective channel between the MNV and dilated choroidal vein. Right fundus shows a relatively large scarred MNV. Wide-field ICG angiogram shows a tortuous dilated vein bending near the fovea and running to the periphery. Upper cephaloma edge is seen as hypofluorescence. These are a series of ICG angiograms, and the bottom is magnified images. In arterial phase at 13 and 14 seconds, the filling of branches of short posterior ciliary arteries are seen. Yellow arrows indicate the same location of short posterior ciliary branches in all images. The MNV area is outlined in red. Yellow arrows are always within the area of MNV. At 21 seconds, especially in a magnified image, a small connective channel shown by blue arrowhead is filled between the MNV and the main trunk of the dilated vein. Please note that this connective channel is not seen at 13 or 14 seconds. The laminar flow in the dilated vein can be seen at 21 seconds, suggesting a slow blood flow of this choroidal vein. And at 3 minutes, the connective channel and dilated vein are uniformly filled. So this may suggest that unlike typical CNV due to age-related macular degeneration, in which new vessels predominantly originate from and drain to the choriocapillaries, in highly myopic eyes with thin choroid and sclera, at least some MNV may originate from the arteriole of the short posterior ciliary arteries and drains through a venule into the nearby dilated vein. The dilated vein may either run to the periphery or exit the eye in the macula. So this may suggest that myopic MNV may be a vascular unit consisting of short posterior ciliary arteries and dilated vein. This may be an adaptive style of MNV in eyes with little or absent choroid. However, as I mentioned earlier, a longitudinal study is necessary to clarify whether this vascular unit is seen at the beginning of MNV or it's a consequence of vascular remodeling. So in conclusions, dilated choroidal veins are present below or around MNVs in about 30% of eyes with myopic MNV. Our findings suggest that macular neovascularization in highly myopic eyes might be a vascular unit consisting of short posterior ciliary arteries, efferent arterioles, efferent venules, and dilated choroidal vein. Thank you very much.
I'm going to talk about multimodal imaging based on subsource OCT in myopic vitreoretinal interface disorders. This is my financial disclosure. The main vitreoretinal interface disorders are vitumacular adhesion or traction, retinoschisis, macular hole that can be lamellar or full thickness, and epiretinal membranes. Several studies show that subsource OCT is superior to spectral domain OCT when imaging highly myopic eyes, especially in the presence of a posterior staphyloma, like in this case, or in this other case, with a concomitant macular hole retinal detachment and a double posterior staphyloma. In this case, we can see that the spectral domain OCT is not helpful to image the whole posterior staphyloma in comparison with the subsource OCT. Vitumacular adhesions or tractions can be very nicely seen with a subsource OCT, like in this case, or this more advanced case, or this case with a foveal detachment that can evolve into a full-thickness macular hole. We know that retinoschisis is the hallmark of myopic tractional maculopathy. We know that this tractional component is one of the leading causes of visual impairment in myopic patients. We can have retinoschisis involving the inner retinal layers, or both the inner and the outer retinal layers. In some cases, can be juxtapapillary, or could have a concomitant disorder like a CMV in this case. In this example, we see retinoschisis in a patient with a choroidal excavation. Multimodal imaging can be helpful in these patients. In this case of inner foveoschisis, we can see the OCTA, we can see the vascularization of the retina, and with the EMPHASE imaging, we can see very nicely the distribution of the cyst in the superficial and especially in the deep plexus. In this other case, with the outer foveoschisis, we can see the cyst in the EMPHASE imaging, and the OCT angiography is relatively normal in this patient. In this more advanced case, with a patient with retinoschisis and choroidal excavation and atrophy, the patch of atrophy can be seen with the OCTA. In this patient with both inner and outer retinoschisis, the OCTA is not very, the quality is not very high due to the presence of the staphyloma, but we can see the vascularization of the retina. Macular hole can be lamellar full thickness. Lamellar macular holes are relatively common in myopic patients. In some cases can be mild, moderate, or severe, but in this case with a huge lamellar macular hole. Lamellar macular hole can be seen with the EMPHASE, you see the distribution of the cyst, or with the OCTA, we can see the vascularization of the retina. In this case, with the EMPHASE, we can see the edge of the posterior staphyloma. In some cases, the retinoschisis can evolve into a macular hole, and it can be small or larger, like in this case. Some cases can evolve into macular hole retinal detachment. In this case, we can see the pre-op imaging and the post-op imaging. A full-thickness macular hole in a myopic patient, we can see the 3D image, the vascularization of the retina with the OCTA, the cyst with the EMPHASE imaging, and the post-op recovery. And we can see the recovery of the vascularization of the retina. And in EMPHASE imaging, we can see the dimples typically seen when we peel the ILM. And in retinal membranes, in this pre-op case, the distortion of the vessels, as you can see with the OCTA, especially in the superficial and the plexuses, the fast imaging, and the recovery after the surgery, and the restoration of the different plexuses of the retina with the OCTA and the fast. To sum up, we can see that structural OCT is clearly better than a spectral domain OCT for the imaging of highly myopic eyes with vitreoretinal interface disorders. And fast imaging is helpful to assess the distribution of cystic lesions in retinoschisis. OCTA is helpful to assess the potential damage over the retinal vessels induced by traction, and OCTA is helpful for the assessment of the post-op recovery. Thank you very much for your attention.
Welcome. I'm Don Hood, and this is a symposium that is part of the iRise Virtual Congress sponsored by Topcon Healthcare. The topic today is OCT and glaucoma diagnosis. Now, I've had over 10 years experience helping clinicians interpret OCT images. So let's start with the tutorial. So I'm going to describe an approach to understanding and detecting glaucomatous damage. And first, my obligatory financial disclosures. I have grants from both Topcon and Heidelberg, as well as equipment. Now, I'm going to address two questions in this brief tutorial. First, what should I look for in an OCT glaucoma report? And second, where can I find it on my particular instrument? This approach that I'm going to describe and the reports I'm going to describe really were based upon a one-page report for detecting and understanding glaucoma that a student, Ali Raza, and I developed in 2014. At that point, it was based on our experience of helping clinicians with OCT for about 4 or 5 years in 2004, by the time we got to 2014. All right, so here's the one-page report. In this case, it's based on 2 cube scans. One cube scan here is centered on the disc. The second is centered on the fovea. You'll see in a couple of minutes that the important point here is that the OCT scan covers both the macula and the disc. And in some cases, you can do that with a single scan. All right, so this is really more than just a report. It's a process or a method. And I'm going to talk about 4 principles or rules that we use. The first rule is you want to examine the circumpapillary B-scan image, and you want to examine it for glaucomatous damage and as well as segmentation errors. So if we blow this up here, it should be large enough and of clear enough resolution that you can see whether the segmentation is accurate, as indicated by the green lines here, and whether there's damage, as you can see locally right there. Right? Now, there are 2 ways you can get this particular image. You can actually get it from a circle scan that's scanned around the disc, or more commonly these days, you can get it derived from a thickness plot. So you can get it derived from this here, for example. And again, you're going to be looking for segmentation and image quality, how well the lines segment this, and you're going to be looking for damage. Excuse me. Okay, the second rule. You want to look at ganglion cell and retinal nerve fiber layer probability, or sometimes called deviation maps. This is essential. So these maps are based on thickness maps, which are also useful. And let me remind you of what a thickness map is before I tell you what the probability map is. So from this cube scan here centered on the disc, this is one of the B scans that make it up. We're going to get retinal nerve fiber layer thickness. And this is a pseudo color plot here of the thickness. And the way you read this is red is thick and blue is very thin. From the cube scan centered on the macula, or the fovea, we're going to get both retinal nerve fiber layer thickness and ganglion cell thickness. So that's retinal nerve fiber layer thickness, that's ganglion cell thickness, and again, dark red is thick, blue is thin. Right now, To get a probability or a deviation map, what the software does is it compares these thickness maps to normative control values. So when you compare this to normative control, you get a probability map here. And now red is bad. And in particular, red means abnormal at the 0.1% level, and red would be 1%, green, yellow would be 5%, and green's within normal limits. We're going to flip this along the horizontal meridian, just the way the image on the back of your eye is flipped, to get a field view. So that damage there corresponds to this damage here, right? And the reason for this is that we're going to compare later on this damage to visual field points. So there are the locations of a 10-2 visual field. Okay, so we're also, so this is the probability map for the ganglion cells. This is the probability map for the retinal nerve fiber layer. And again, these are in field view. So this is based on this and this stitched together, field view. And again, dark red is highly significant at the 0.1% level. Green would be within normal limits. And then this, as I've already described, is the ganglion cell thickness map. All right, rule number 3, you want to look for topographical agreement of glaucomatous damage within a report. So let me unpack that. What we're looking for is something that's characteristic of glaucomatous damage, and that is typically an arcuate. So I want to remind you that because the axons from the ganglion cells arc around the fovea when they enter the disc, and because glaucoma acts at and in the disc, damage here creates this classic arcuate kind of pattern. So you're going to be looking for damage that's arcuate in nature. The second, which I'll define better in a moment, is everything should agree. That is, the different parts of this report should agree. Now, to make that easier, what I'm going to do, or what we recommend, is that this get presented in an N-stin plot, where T stands for temporal, and that's the middle of this. So you might say, what's an N-stin plot? All right, so let me take a moment to describe that. So in a sense, what you're doing is, if this is the center of fixation here, and this is an 8 degree, plus or minus 8 degree circle, this is plus or minus 8 degree on your thickness plot. To understand this, let's go back to what you're more used to. What you're used to, starting with the very earliest Zeiss reports, is what's called an N-stin, a T-snit plot often. And that is called a T-snit plot because it is plotted the way the scan goes, which is from temporal, T, to superior, S, to nasal, N. You get the picture, T-snit. The problem with this particular plot, when you're trying to understand the relationship to topographical parts of the retina, is that it splits the macula in half. So that's plus or minus 8 degrees now split in half. Whereas if you plot it as an N-stin, that is, you plot it as if it starts in nasal. So now it goes nasal, superior, temporal, inferior, nasal, N-stin. Now the macula is in the center of the plot. This is the temporal half of this region, which I'll show you in detail in a moment, would represent on your visual field about plus or minus 15 degrees plus the nasal step. So here's a little diagram. This is the region that represents the macula, which is plus or minus 8 degrees. This is the temporal half here. So this is the temporal half. And that temporal half represents about plus or minus 15 degrees plus the nasal step. So let's go over here. And this is the region of the retina that's represented by this region here. And so if you put on the 24-2 visual field points, you can see that the temporal half is about plus or minus 15 degrees plus the nasal step. Okay, so back to this. We're looking for damage that is arcuate in nature. And everything should agree if it's glaucoma and not an artifact. So what everything should agree is in this, let's use this as an illustration. You can see that this is thin. This is the region that's being affected by glaucoma here. That region corresponds to this here and corresponds to an arcuate that looks like something about like that. So this location here is topographically identical to this location here. It's identical to this location here and is associated with this arcuate. Okay, the final rule is if you want to compare the visual fields, which is one of the main clinical objectives, you want to use probability and deviation maps from the 24-2 and 10-2. You do not want to use visual field metrics such as mean deviation, pattern standard deviation, or glaucoma hemifield tests. So let me give you an illustration. Here's the 24-2 for this patient. You can see there's a nasal step here. You know, these are the points that are abnormal here, right? And you can see it's consistent with an arcuate, right? But notice this can miss macular damage. This is why it's so important to get 10-2s. So here's the 10-2 for this patient. You can see some damage here, right? We'll put the points over here, add the abnormal regions, add them here, and you can see that in this case here, and this is not atypical, that you've got clear macular damage confirmed on the 10-2 that's being missed by the 24-2. Anyway, rule number 4, don't compare metrics, compare probability maps. Compare this to this. Now you might be saying, but wait a minute, aren't you assuming that we can compare abnormal regions? And I would say, yeah, that's what I've been saying. And you might say, well, wait a minute, I've been taught that structure comes before function. Well, the truth is that is not technically correct. If you use probability maps like this for both ganglion cells and visual fields, and if you compare it to local abnormalities on the field, then structure function agreement occurs in the overwhelming majority of eyes. All right, so that's the answer to the first question. The answer to the second question, I'll be brief because we're going to review this in our next section. And that is, where can I find this on my instrument? So we're going to be showing reports in a moment from 3 different manufacturers. We're going to be showing a report from Zeiss, a report from Heidelberg, and a report from Topcon. So let's do the Topcon first. The Topcon report, which is called a 3D wide field glaucoma report with visual field test points, or the Hood report, is available for the Maestro instruments and for the Triton outside USA. And it's based upon our lab report. It's also based upon a 9x12 single scan. So this 9x12 scan includes both the macular region and the disc. If we take one of the B scans and blow it up, what the algorithm does is measure retinal nerve fiber layer, it measures ganglion cell layer, and it produces this report. This circular image here is derived from the same cube scan. Okay, so again, this is in NSTIN, so that if we blow this up, you'll see this is your macula plus or minus 8 degrees. This is your temporal half, which is plus or minus 15 degrees plus the nasal step, NSTIN. So remember, rule number 1, you want to examine this for glaucomatous damage and segmentation errors. There's some damage, and you can see there's no segmentation error to speak of. Rule number 2, you want to take a look at ganglion cell and retinal nerve fiber layer probability maps. So again, let's review. This is the thickness map. This is the probability map for the ganglion cells. This is in retina view. This is flipped along the horizontal to be in field view. This is the thickness map for the retinal nerve fiber layer. This is the thickness map. This is the probability map for the retinal nerve fiber layer. Rule number 3, we're looking for topographical agreement of glaucomatous damage. And all of these red arrows are topographically identical points. So we should be seeing similar things. Red here, defect here, thinning here, thinning here. These black arrows are also topographically identical, and they're consistent with the arcuate that's associated with the red arrows. And we'll come back to that point more than once. All right, the Heidelberg report, also based upon our lab report. There's a US version, and then there's a version available outside the US. We're going to be presenting this one because it's got the probability maps. So again, retinal nerve fiber layer thickness map, retina view, ganglion cell thickness map, retina view, end-stent plot. You can see the same places with agreement. This is the same eye. All of that's in retina view. Over here in field view, we have the retinal nerve fiber layer probability map and the ganglion cell probability map. The one thing that Heidelberg does differently that's different in this ICE and different in the TOPCon is, in addition to showing significantly thinned areas, it shows significantly thick areas. So the other maps, this would be 1%, this would be 5%, and this would be 5 to 100%. In this case, they show significantly thinner. So if you want to make this, if you want in your mind's eye, if you want this to look like the plots I've just been showing you, turn all these to green. Finally, this ICE report, right? This is the one that you're most used to. It doesn't include the ganglion cell scan. There's a separate ganglion cell report that I'll show you in a little bit later. But for now, I just want to tell you we're going to be using this ICE panel map because it has some of these same characteristics. In particular, this is based on 2 cube scans. This photo is not from the same eye. And so so you get thick, this shows you the retinal nerve fiber layer thickness map for these 2 cube scans. So that's the thickness, retinal nerve fiber layer thickness associated with this scan. This is the one associated with that scan. And here are your deviation probability maps. Now, it's a little tricky because the deviation probability map combines the retinal nerve fiber layer probability map with the ganglion cell probability map. And we'll review this again when I show you the first case in a couple of minutes. This is a derived cervical scan, just like I was telling you about in TSNIT. I believe the software now allows you to click a toggle and get end-stent. All right, so we'll review those reports again in a moment, but this wraps up my tutorial. I just want to mention my collaborator of 10 years, Gus Demores, and all the examples here actually come from a data set he's been working on, and the patients were referred by our colleagues at Columbia. Here are 2 short reviews that we wrote for the clinician that's available. And here are 2 longer reviews if you're really a glutton. And then you can visit my website and actually get these papers, but also recorded lectures that I've done in the past. cell probability map. And we'll review this again when I show you. Here's Augusto Mores, and all the examples here actually come from a data set he's been working on, and the patients were referred by our colleagues at Columbia. Here are two short reviews that we wrote for the clinician that's available. And here are two longer reviews if you're really a glutton. And then you can visit my website and actually get these papers, but also recorded lectures that I've done in the past. Is Augusto Mores circles available, and here are two longer reviews if you're really a glutton. And then you can visit my website and actually get these papers, but also recorded lectures that I've done in the past.